Hips. Somebody comes in with hip pain. I've got tight hip flexors. I have sciatica. I've got, whatever's going on. How often is it actually the hip? Hip's fault. How often is it usually the hip's fault? Rarely. Just like when somebody comes in with low back pain, how often is it the back's fault? Almost never. It's almost never, right? So when we start to just kind of take that perspective of, okay, yeah, you have your pain there, it's coming from someplace else. And then if you clear it and screen everything, and you're like, well, everything's moving great, okay, then it might be locally coming from that. But 9 times out of 10, it's not. So people come in, I got groin issues, I've got tight hip flexors, I've got athletic pubalgia, I've got piriformis syndrome. Rarely, those are symptoms, but you just got to start asking what's the cause, right? Usually happens. It's like it's a general term for when you have pain in the adductor into the abdomen, and it's typically from hockey players or soccer players who are kicking a lot or pushing off a lot. So they just, again, why do we put fancy names on shit? Yeah. Other than it's groin pain. Yeah. Yeah. So you have groin pain. You have like patellofemoral syndrome of the knee, but for the groin. It's just a fancier name. And you sound like an athlete. It's shin splints. Got it. Okay. So we'll go through. We're gonna use Kylie as our model. And I've seen how you move, and I have some ideas of how the hips might be affected, okay, which will be great. You'll be a good example for a lot of the things that we'll be covering. But first, we're going to look at how you move. Is that okay? Yep. So come on over here. That's okay. Okay. So stand. We'll go feet together. We were done your posture assessment where it's gonna. So bring your chin to your chest. Good. Any pulley tension stuff there? Good. Look up towards the ceiling. All the way up. Any pinchiness here, any pulling in the front. Good. So, Mike, look up. So, chin down. So, not bad. Yeah. Big hinge. Look up. So, hingey there. Like, range of motion is good, but hinge, but no problems, right?
No problem.
Okay. Turn your head to the left. Turn to the right. Rotation looks good. Ear to shoulder. Ear to shoulder. All right, so she's got lots of range of motion there. But we see a hinge there. Are we concerned about it? Nah, not yet. But we're going to remember that. Bend forward, touch your toes. Can do that.
Can do that.
Okay. Okay. So we flex here. We stay flat here. Okay. Come on up. Arms up overhead. Lean backwards. Any pinchiness back here. Any pulley in the front. Okay. And we hinge here. Okay. So we've got 2 hinge points. There and there. Okay. We're going to remember that. Arms at your side. Give us a little rotation. Nice. Left rotation. One side feel different than the other?
This one feels more, but that's my throwing side. So.
Easier, right? Yeah. So, but that's relevant, right? So you rotate, lots of rotation there. Go the other way. Still pretty good. Okay. Hips maybe don't want to come around as much, but that's okay. Arms up. Give us a little side bend. Boop. And the other way, lots of side bend. Good. So already we're seeing you move really well. Okay. When somebody moves well, but we see kind of these hinge points or these areas that might be moving a little bit too much, do we have to potentially give you mobility stuff or strength and control stuff? Yeah, right? So already our head's going to the strength and control kind of algorithm side of things. Okay, and where do we find most of our strength and control? What test? Single leg balance. So hold that right there. Good. So I'm looking to see you hip hiking. Now close your eyes. 9, 8, 7, 6, 4, 3, 2, 1. Okay, pretty good. Good. Left foot. Find your balance. Eyes open to start. Close them when you're ready. 10, 9, 8, 7, 6, 5. A little bit off on that side. Okay. So you're able to catch yourself, but then you really start to lose position, right? You start to find something else that you can kind of organize. Cool. Okay. Give us a little squat.
All the way or just
all the way? Yeah. See what you got. Again. Nice. Okay. And then we'll do triple flexion. So single leg, air lunge, hold, come on back up, and switch legs. Does one leg feel different than the other? Yeah. Left. So left single leg balance, left triple flexion extension. Exactly. Little different. Okay, cool. Have a seat on the edge of the bed. Yeah, okay.
So you need to go nearly as far, like
Right.
squat and lift in and single leg.
Yeah.
Triple flexion, then go nearly.
Yeah, right. So lots of old ankle sprains on the left side. Proprioception's different on that side. What might Kylie come in with from a presentation perspective if she was saying, I've got, what hip do you might think would be the painful hip? Yeah, right? Especially if there's lots of running, jumping, squatting, because your brain knows, well, that side's the weaker side. I'm going to shift to that right side and load up the right low back. Typically what happens. Not all the time, but sometimes. Legs together, chin to chest, curl down, all the way down. Good. Any pulley tension stuff? Slowly straighten the left leg, toes up. Any pulley tension?
Little like neural behind the knee.
Okay, keep the leg there. Look up. Better, worse, no difference.
No difference.
Okay, keep the leg there. Keep the head there. Lift up. Better, worse, no difference.
Better.
Better. And then come up. Better, worse, no difference. Better. Okay, so T-spine down. Good. All the way down. Right leg up. What do we got there? Same thing. Look up. Better, worse, no difference.
A little better.
A little better. So C-spine, T-spine, and then lumbar. So a little bit different right and left. Cool. Arms across your chest. Rotate left. We got rotation. Yes, we do. Go to the right. One side feel different than the other? About the same.
I think I got a little more this way.
A little bit more going to the right? Yeah, a little bit. But if it's hard to eyeball it, yeah, subtle. Right? So we're looking for like those major.
Yeah.
Your flexion was way more restricted. Your extension was more interesting.
Yeah.
All right. Yeah. So swing your legs. Let's just from a flow perspective, scoot your legs all the way down to the edge of the table here.
Like knees.
Yep. Bum, bum, bum. Glutes.
Glutes.
Turn yourself into a little ball. Bring your knees into your chest. Good. Drop the leg. Any problems there? Do we have tight hip flexors? No. Right? Switch legs. Leg hits the table. Modify Thomas. No problems. So TFL, not tight. Rec Fem, not tight. Psoas, not tight. Great. Guess what you don't have? Tight hip flexors. Awesome. Go up. Myotomes. Big toe up towards the ceiling. L5, toe down towards the floor. S1, foot up towards the ceiling. Push up. L4, kick up into my hand. Kick. L3, hold the leg. L2, hold again. L1, nice. Good. Check the other side. Big toe up towards the ceiling. Big toe down towards the floor. S1, foot up towards the ceiling. Push. L4, kick up into my hand. L3, hold the leg. L2, hold again. L1. Now, based on her spinal presentation, if we were to drop her head into flexion extension to sensitize it, which direction might we find a little bit more sensitization? Yeah. Extension, because she loves extension, both in her neck and her lower back. And the slump test wasn't really that conclusive, right? She has, like standing flexion is a little bit restricted, but the slump test was not that big of a deal. So if we drop the head and we go into some extension, big toe up. L5 is still good, big toe down. Spine, foot up towards the ceiling, push up. L4 still good. Kick up into my hand, kick. L3, hold the leg. Hold. What happened to L2? Hold. Hold. L2, hold again. L1, fine. Cool. So L2 got a little sensitive. Okay, and that could be maybe where you're hinging. Big toe up, big toe down. S1, foot up towards the ceiling. L4, kick up into my hand. L3, hold the leg. Hold. L2 is better on that side. Hold. Hold. L1. Pretty good. So a little L2 on that side. Okay. But in single leg balance and your history, what might we be more interested in? Yeah. Okay, so let's look at passive straight leg raise. Okay, some tone there. More tone on that side. Have you always had kind of toned up, tight hamstrings? Okay. Lift that leg straight up in the air for us. Good. Go back down. Lift that one up. Still heavier on that side. Yeah. Okay. So we'll get back to that. All right. Hip scour. So let's start clearing the hips. Any pinchiness as I rotate you around? Nope. Good. So we look at passive range of motion, looking for 40-50, 30-40, a little tight. Favors. Any problems with that in the front? Anything in the back? No. Just for funsies, bring your hands up, one on top of the other. Push your hands into my hand and let the hip fall. Didn't change it that much. Sometimes the hip opens up because we centered the pelvis, we activated the core, and the hip flexor rotator muscles of the hip get to relax because they're not trying to protect or stabilize the pelvis, right? For you, it didn't change that much. So we're clearing out kind of top down. So 30, 40, 40, 50. Let the hip open. So symmetrical. Okay, hands up. Push your hands into my hand. Okay, no change there. No. And let's just check the scour real quick. Any pinchiness in here? You can use, if you do a hip scour and you do that core activation, sometimes it clears it out of the way. So you'll get somebody. So if you have the control, so if I can perform the test with one hand and find it, sometimes they're like, oh, that's pinchy. Bring your hands up there, Kylie. Push into my hand, and then I do it again. It can clear it out of the way. Okay. Or what I also I can do is reach up towards the ceiling. Yep, both hands, and do a little sit up. Yep, and then yeah. Because now I know, because when she sits up, what did she do? She posterior pelvic tilted. She set the pelvis in a different, it gave more space for the hip. Now you know it's a functional hip impingement. If it didn't change, well, maybe it is more structural, right? Maybe there's a labral tear. Maybe there is an FAI. But if by facilitating the core, setting the pelvis, changing the position here, all of a sudden you're like, it's not an FAI.
How do you differentiate like labral tear from FAI?
So a lot of it's going to be symptoms. So if they're coming in and they're like, I have deep pain, and they're doing this, C sign. Typically labrum or OA or something inflammatory, intracapsular or intraarticular. Okay. There are some of the ligament tests. Again, tubofemoral, ischiofemoral ligaments, like you're getting in there and you're feeling, I don't know. For me, if they're like, there's a ton of guarding with the Faber's test, and the core kind of helps it out a little bit, and there's a positive hip scour, or, you know, say I come in, again, like, how big of a tear and a loss of intra-articular pressure is going to change that? I don't know. Because if they've got a lot of muscle guarding, it's just going to hold the hip in the socket, right? History is going to tell you a ton, mechanism of injury, and then some of these kind of functional tests. And it's going to determine if they're responsive to rehab and exercise and they're getting stronger, why would you send them for surgery anyway? It's like, okay, we've been doing all the stuff for like a month, 6 weeks, nothing's changed. We need to get further investigation. So it's really how they're responding, because even if they're a responder to rehab, why would you do surgery anyway? Right? Like, let's prolong it. Like, let's see what we can do. Yeah, like people are walking around with labral tears all the time. Not a problem, right? Until it becomes a problem, and then, you know, you feel that stiff, locked up OA hip that's not going to change. Well, now we're at a hip replacement, right? But those are the people that you wish you saw 5 years ago. Could have did something about.
Still have to work through the muscle definition. You still have to work.
Exactly. Yeah, you got to repattern. You got to take away some of the protection, the guarding, repattern them in with proper strategies. Okay, so looking at what Kylie's got going on here. So we have more neural tension on the right side. But what else do you have better? What's better on that right side? Balance. So what do you think you might be doing a little bit more on that side?
Favoring it.
Yeah, right. So you're going to load that side. It is going to be tighter because you're just compressing that side. Neurologically, structurally, all the stuff. This side, because you avoid it, it's going to have a little bit more mobility to it, right? So before we get down into there, I want to see what kind of control we have here. So lift this leg straight up in the air. Remember how heavy that leg felt?
Yep.
Go back down. Push your head up into my hand. Push up. Lift the leg. Harder, easier, no difference?
A little easier.
A little easier, right? So we stabilize the neck, stabilize the core. Nervous system's like, oh, I like that. Okay. Lift again. Go back down. Push your shoulder up into my hand. Lift that leg. Harder, easier, no difference?
Amazing.
Yeah. So for you, we're doing dead bugs, but we're going to incorporate the neck, right? To kind of get the sling system. Try this leg. Lift that leg up. Okay. Remember how heavy? Push your head up. Harder easier, no difference.
About the same.
About the same, right? So that side, this connection is working fine. Push your shoulder up. Now lift that leg. Right? So you have good cross-cord connection here. It's this side that's a little bit off, which makes sense.
Yeah.
Right? Single leg balance on the left. Cool. So since we're here, let's check some muscles. Hold the leg, don't we twist? Hold. So local deep hip rotators are working. Hold, don't we push? Good. Bring it up. Hold the leg right there. So psoas. Good. Okay. Now for fun, let's check the deep hip rotators with the ER chain. Hold the leg, don't we twist? Well, that's good. I was expecting that not to work. Don't we push? IR chain. Good. Hold the leg. Don't pull, let's do adductors first. Hold. Adductors. Good. Abductors push out. Good. Connect the foot. Push. Abductor. Push out again. Oh. Oh. Push out. So hip on its own works great. Abductor chain with the peroneals, not so good. Right? So now if we test the foot here, don't we push you in? Push. Okay. Go a little bit weak here. So what do we need to work on? So if you came in, you're like, oh, I have this lateral hip pain or trochanteric bursitis, and the hip's not working. It's the lateral chain. The foot's shutting off the hip. So we got to do local ankle stuff to settle down the hip. So we have a bottom-up problem, not a top-down. Right? So adductors, hold the leg, don't we pull? That works fine. Okay. Flip on your side facing that way. We'll look at modified obers. Okay. Leg up, let it come up, let it drop down. Okay. Pretty good? Yeah. Right? So we'll check the other side after. Okay. But for fun, bring that up, push the hand into the table. Okay. And then let that hip fall. So sometimes when you've got that positive modified obers, because they're losing pelvic control here, core facilitate, all of a sudden the hip lets go. Same idea, right? We're just adding different position here, and the hip is getting less tight. Yeah. So then, yeah, exactly, right? It's just all you did is facilitate the obliques and the QL, and all of a sudden we got better organization down below. The hips aren't locking in. The IT band is not pulling on the knee. So it's just like, well, let's just do some, if they can't do side planks, and sometimes they can't, core facilitated clams. That's fine. Core facilitated hip abduction up against the wall. That'll all wire that back up. But the point of it is take care of this, not stretch this. It's too often a stretch and needle, and that's the problem. What are we doing? Right? So relax the hand. So we'll check the muscles. Hold the leg right there. Push up. See, abductors work great. Push up. Not so much with the foot. So again, confirming that the foot is shutting off the hip. Okay, so we got to do foot stuff, right? So you don't have to sit there and beat the crap out of your glutes. Lift this leg up, push up. So adductors, push up, adductor chain, fine. Flip to the other side. So this side might be, quote, tighter because you use it a little bit more. So yeah, you kind of hang up there a little bit. Okay, let's bring that up. Push the hand into the table. Good. Does that change position? A little bit, not so much. Okay, so let's check the strength. Hold up, push up here, push. Good. Push up. Didn't change. So on this side, maybe we want to do some soft tissue work. Maybe we need to do some releasing in the glutes, just to kind of get it to relax and create space. Right? Make sense? Strong, but it won't let go. Right? So as we come up, she doesn't come into that. And even if push the hand into the table, or Kyla, core facilitation didn't change it that much. Right? So everything's testing strong. It's probably not that much of an issue. Right? So say it was weak, you know, you have her core facilitate and come on up. So lift his leg straight up in the air. This is where you can kind of play. Remember how heavy that felt? Go back down. Okay. Push your hand into the table. Lift the leg. Harder, easier, no difference. No difference, right? So even getting her to actively do it didn't feel a difference, right? Push your head up into my hand. Lift that leg. Harder, easier, no difference. No difference. If you got to think about it, if I hear, I'm going no difference, right? So going all the way up to the lateral chain right into the neck, you might need to bring in the neck or take out the neck. So if someone really responds to that, getting them to actively hold their neck in space and do some hip abduction more beneficial. If it makes them worse because they're compressed, support it, keep it out, right? Go into your tummy. I think this is where it's going to get more interesting. I know. All right. Head in the hole. So this is where, so Kylie had a little bit of tight hips at that 90. Does she have tight hips anymore? Not really, right? She's got really good rotation here. So you're doing your Craig's test to confirm, you're like, there's a little bit, maybe capsular. It's not. It's more fascial. The capsule's winding up, but it's not articular. She would still benefit from some release work, maybe some needles. It'll respond faster, but it's not like true capsule joint, right? And then you look at your your Craig's test here. Where's the position of her hips? She's actually a little anteverted. So that's where that trochanter pops out. And then I measure from there. Internal rotation more. Yep. So this hip, so both. She's about maybe 10 degrees anteversion.
Anteverted, what considerations change for you to, you want to open the space, I guess, in the front of the hip?
Yeah, because they're going to be more biased towards punching out the back. So you might want to be doing a little bit more like an anterior glide lunge stretch. Someone who's very anteverted, don't give them pigeon. That's going to destroy their hips because they just anatomically can't go there. They're going to pinch, they're going to compress. It's not going to be worth it, right? So, but Kylie's got lots of range of motion.
You're already biased to there. Why would you pigeon further?
Because oftentimes people are like, I can't pigeon pose, I can't cross my legs. Yeah, because you have 70 degrees of internal rotation and you have 20 degrees of external rotation. So you have your full 90, it's just way over here. So we're not going to do that. We're not going to push into pigeon pose or a lot of external rotation because your hips just anatomically don't do it. So let's not cause problems.
What do you do for these people? You just train them within their available, like...
Yeah, they are not squatters. I don't give them squats. Not much. At least not for a full range of motion. Definitely not back squats. Goblet squats with a wedge to try and find some space for sure, right? But they might be more narrow. They're not going to be wide. Okay, that's okay. But single leg, step-ups, Bulgarians, lunges. They can do all those. That's fine. It's just the hips, when they're together, they're not going to find the space to open up. That's all. Yeah, you just need to give them a little bit of a mechanical advantage someplace else if you want them to squat. But I don't have them squat deep. So whatever range they have available.
Just like that. It's so weird.
Yeah.
She has a capsular restriction plus extreme, most introverted person I've ever seen.
Yeah.
It's like her hip IR, she's like very good parallel with the ground. She does it.
Yeah.
So like very little ER, but it's also capsular ER on the side. So
sure.
Exactly.
Yeah.
Get back those kind of
yeah.
No hip extension. So,
right. So I would focus on the hip extension for gait. Yeah.
I think if she's running, so she'll get it'll get irritated a lot.
Sure.
Like it's trying to open it up, but it's also so cemented. Trying to open it is. We do some. She can tolerate pigeon, but she can't like. She'll get irritated with the pigeon right under her head. She'll get back stuff. Instead, so.
Yep.
If they're retroverted, so then they're more of your squatter.
Yeah, they're better squatters, but they're not fast runners.
Yeah.
Typically, if you want to be a little bit faster, it's better to be a little anteverted, toe in than toe up, because there's more, you're fascially and kinetically locking into the joint to push off. It's just more stable, but it's going to be more stiff. So depends on what you want to do. Do you want to be, like ballet, turnout, lots of ER because they need it. But for people who can't get a plie or turn out properly, don't expect to go far in ballet because anatomically you can't do it.
So, like, how much change do you try to make it enjoy? But okay, you have most of that already.
Yep.
But you are really restricted. Let's say, or case or whatever. So you are really restricted ER, even though you have provision. You're trying to get more ER there
if it's available. So again, we're going to use kind of general range. Like we're looking for a total arc of 90. Yeah. If there's a little bit more available to them, we'll go for that, right? Because they might just have shallow hip sockets, and you can play with that range of motion. If you're feeling the joint and it's like really hard, jammy, you're probably not going to get much more out of them, right? Like you're hitting the end range of their anatomy. So it's like, oh, it's a little springy. We've got, if I go to R2, like there's more R2 here. But if it's like a hard end feel, probably not going to get much more range out of them. Yeah. And then, but also you're measuring, because most hips, it's a full arc of 90, most hips. And if they're lacking the 90, then you probably have some wiggle room. And that's where the Craig's test is going to help you determine, where's my wiggle room? Oh, my wiggle room is actually an IR. I can get a little bit more out of here, right? So if they're retroverted and, they're way over here, well, I'm like, okay, I need to get more internal rotation. I got more wiggle room this way because the total arc is not achieved.
Yeah. But if she had total arc of 90, but was still super retroverted, it's like, it's hard, that's it.
Yeah. 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 If it's total arc of 90 and it's hard end feel, probably not going to get much more out of them. Yeah. Okay. So with Kylie, lift the leg up there, my dear. Hold it right there. Push up. So your poor glutes aren't helping you out too much. Lift up. Okay. All right. So if we get your neck involved, push up into my hand. Push up. 3, 2, 1. Keep it there. So by facilitating the neck, hold, push up. Different, eh? Yeah. Keep the head there. Hold up, push. Yeah. Okay. Now if you pick the head up, right? We kink the hose. Hold it right there. What happened? Lost the glutes. So your neck, the position of your neck is determining your power output down below. So it's positional inhibition. So for you, if we're doing fire hydrants, we're doing glute activation, we need to make sure that neck is locked in. So that's where when we put the bands around the neck, yeah, we're trying to get them into a better position. Now, if that made you worse, then I'm like, okay, we need to keep the neck out of it. For you, we need to bring the neck in. So relax the head. Lift the whole leg up off the table. Okay, remember how heavy that felt? Push your head up into my hand. Lift up. Leg. Harder, easy, no difference. Easier, right? Go back down. Lift the leg. Remember how heavy. Back down. Head up. And leg up. Easier, right? Yeah. Okay. So now we know banded bird dogs, right? If we wanted to bias glutes more, then we can do banded fire hydrants. The idea is just to get the neck involved. Okay. Cool. So Eli's tests, again, does she have tight quads? No. Not hypertonic. So we're looking to see, am I bringing her here? And then she's twisting. And then even with that, if modified Thomas was kind of a negative test, it still might be hypertonicity. She might be pulling from the quads, maybe for an L2, maybe because her hip flexors aren't helping out. So she's making those, those quads, especially rec fem, hypertonic. So, we're not going to do, might not have to do a ton of stretching. Maybe you do, depending on like, oh, easy, 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 and then twists, probably hypertonic. If it's like tight, 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 a lot more stretching. So I need to release, dry needle.
When would you look at that and be like, okay, we need to do some femoral nerve things?
Well, you can test the femoral nerve, right? Do you know how to do it? Okay.
Or just biasing the neck instead.
Yeah, but so flip on your side, Kylie, towards Michael. Basically, the femoral nerve, like it's basically this. And you're doing a little bit of external rotation. And then you can slump and see if that, I don't find that very often, to be honest. Because what's the nerve root for the femoral nerve? Again, names are fine, but they're not helpful. L2, 3, 4. What other myotomal tests can we use to find L2, 3, 4? Your myotomes, right? And where was she more restricted? Flexion or extension? Yeah. Right? So if they're coming in, they're like, oh, like it's really pulling in the front, or like I feel it going down my leg, then maybe, yeah, let's check the femoral nerve. I don't find it overly helpful because it often gets trapped kind of in the front, maybe around the hip flexors. A modified Thomas is going to find that too, because you're putting them into that full, this position. And if I want to bias it, I just have them, can you pick up your head? Oh. So there's, yeah.
The only thing I would think is if I'm doing that, like,
yep.
I'm getting like tons of hip lifting, whatever, like, is it if it's technically abdominal or plantar, if it's whatever, but I'm like, okay, if they're lifting up their head, it's getting worse. Am I dealing with just like a fascial?
Sure.
Maybe.
Yep. Global extension. Yeah. Where do you feel that? I feel like often what you'll see is like, I'm getting a pinch there. I'll stick my finger in the level of where they're getting their pinch. I'm like, oh, is it right here at the hinge? And then I'll stick my fingers in the obliques. They're like, oh, it's gone. Okay, so we have muscles in the back fighting with muscles on the front. So we're tight. We probably have to. Oh, is that tender? Yeah, it's a little tender. All right, we're going to release that. So you know,
lots of different ways to get to that.
There's lots of different ways to get to that. So I don't find the femoral. I don't do it often. Therefore, I'm not going to be very good at it. But I can find neural tension in so many other different ways.
It will pop out at you later.
Yeah.
Rarely got maybe once I had where I did that testing.
Sure. And was it right down the front, or was it kind of this lateral? Yeah. So which one is that? Yeah, lateral cutaneous femoral nerve. And often, why does that get tension? Or does it get trapped between TFL and glute medius? So as soon as you release TFL, glute medius, that nerve releases. And what acupuncture point can you use? Yep, JK back here, but one goes right here. Gallbladder 29. Yeah, 30 is right behind it. Yeah. So again, you've got tools to release that nerve. And then what test that we just did is going to kind of pick up on some of that femoral bulbers. So you're kind of, all these tests are a little redundant if you know how to apply them.
Where it's going.
Yeah, and okay, what am I stretching? What am I stressing? What am I, well, this is changing. It's just like with the kinetic chain muscle testing. We did it in a couple different ways, and it confirmed we have to go after that ankle. It comes up 3 different times, which is why we keep cluster testing, and a lot of them are redundant. We just need to know how to interpret the tests and how to just kind of change their interpretation. It's not just for one thing. It's for many things. You just have to understand how it's all connected and why it's relevant. So that's why it's fun. And that's why we can also distill down the number of tests we need to find the problem. Because
something comes up there and you're like, okay, now I'll go down this rabbit hole.
Yeah.
Otherwise I don't need to.
Yeah.
Oh.
Yeah. So you stick to that main algorithmic pathway, and then oftentimes you get to the 4th or 5th section, you're like, we're going to stop here, and we're going to treat these things because they're really popping out, which is a lot of neuro. All right. And then the next time you're like, well, these are cleaned up. Go to the next step. Oh, that's clear. Go to, step 7. We're stuck here again. So, I mean, it's a simple roadmap. And I don't know how many times you fix people just from doing the neural stuff and going after some of the fascial restrictions in that local, and all of a sudden things start to reorganize. You're like, well, you had all these other things, but just by treating this one thing, this primary driver, it cleaned up the second and tertiary. You just don't want to complicate it. I think we complicate it, right? And that's why it seems like you're like, everyone's getting bird dogs. Well, because they can't control their spine in those positions. Why would you give them something advanced when they can't control the fundamental position? Makes no sense. Well, how come everyone's getting bird dog? Because they need to work on their slings and breathing. Because they can't hold it in an upright position. Why would you not start there?
How would you progress bird dog out of sport?
Out of spine supported? How would you do it?
I would probably do any kind of roll work, pull work, crossbody.
Yeah.
I know. I'm suffering.
Single leg deadlift is a good one. I would go, even though from if the idea is posterior chain, I would do single leg glute bridges, like marches, because now you're getting more push-pull compression going in the posterior chain. It's a little bit different, but most people, they have difficulty with that, finding their spine in space before they drive through the ground. Like just lifting the leg is too hard before they lift their body. But again, this is a bird dog. Loaded, so glute, pull, posterior chain. Anything unidirectional, it's a bird dog. But that's why the single arm, single leg, push pull stuff is, we're just going after cross cord. Bird dog is just where we start, and then crawl them. Okay, so teach them the position, teach them how to move into that position and posture, and then get them to move out of that position or posture and make it more locomotive and more relevant. And that's where the crawling comes in, backwards. And then if they crawl forward, now crawl backwards, and watch how they screw it up. They fall apart. You're like, okay, we got to do some backwards crawling. Now, is it hitting the same posterior muscles? Not really, but the different types of crawls will do it. But anytime you're just going to start to pull something, well, now you went back to the posterior chain, cross cord. Make sense? And so in the standing positions, we've jumped a step. Where could we go before that?
Oh, yeah.
So suspended, right? But going from suspended into standing, kneeling. Exactly. Exactly. Yep. Does that make sense? Is there anything that you want to kind of like feel, practice handling? Try maybe modified Ober's test or modified Thomas test, myotomal, like hand positions.
Yeah.
Because the myotomes are, again, they're key. Hand positioning matters.
Yeah, no, those are important. Like for behind your back. That quickly. You have L1, 2.
Yep. So L1 umbilicus.
Yeah.
L2. Okay. L3.
So
Just walk underneath. Right. Yeah. And then S1's toe flexion. And then L4, 5 is also deep hip rotators. Yeah. Right. So you can kind of confirm. You're like, maybe. And then using that bigger limb might be easier to find it.